In this lecture, we'll be talking about the 5 cardinal signs of local inflammation. In this lecture, we'll be talking about all of the causes and characteristics of inflammation in general, with a focus on acute inflammation, which is much more local inflammation. This is just a reminder that when you're having an inflammatory response, that's actually a protective, non-specific defense against pathogens. So we'll be talking about the qualities of inflammation, and in that we will also discuss pyrexia or fever. In the last part of this lecture series, we'll turn our attention to tissue repair, which is what happens after the inflammatory response. As you know now, the rest of the lectures in this section will deal with the rest of the white blood responses and the immune response. So let's get going. We're going to be talking about, again, the causes and characteristics of, first, local inflammation. So please remember that inflammation, even though it feels really awful, is a very important protective response. It is non-specific. This is a very early response when tissue is injured. So keep in mind this general idea about why we have inflammation. Ideally, we want to destroy the pathogen. If we can't do that, we'll wall off the pathogen, and we'll talk about that in chronic inflammation. We also want to contain the pathogen in one area so it spreads as little as possible. When we're done fighting the pathogen, we need to clean up the mess and then create new tissue. This part right here, again, is not covered in this lecture. As we focus on inflammation, we will be talking about whether it's an acute response, a very short time-oriented response, or chronic response, lasting over potentially a lifetime, and whether it's local versus systemic. In this lecture, we'll focus on this end of the spectrum. So all of these things can cause inflammation that starts with damaging the tissue, and there's lots of things that we've talked about already that can cause tissue damage. Stop before you move on to the next slide and remind yourself what the 3 primary mechanisms of cell injury were and which one is the most prevalent. So stop before you move on and think about that. Here's another way to kind of remember different things that could damage tissue. Little mnemonic for you is first tick, the first letter in each one of these letters. So you can have foreign intrusions, so you get a splinter or a cut. You can be dealing with a pathogen, and we talk about that in our immune response. There can be damage from radiation or from surgery or any type of physical trauma. Temperature extremes, think about burns, or on the other side, freezing temperature like frostbite. Ischemic damage, remember ischemia means decreased oxygen flow to the tissue, and then caustic chemicals like lye. This is a reminder slide from our early lecture when we talked about causes of cell injury. Remember those reactive oxygen species, including free radicals, can damage cells. Hypoxia, and therefore ATP depletion, is the most common cause. And then we talked about any changes in intracellular calcium, where calcium comes into the cell for some other reason and changes the activity of the cell. Just a reminder that those are cell injury causes, and therefore they're tissue injury causes, and therefore they will lead to inflammation. So remember that inflammatory disorders are named by putting the word itis after the area of the body that's damaged. So hepatitis is liver inflammation. Gastritis, for example, is the inflammation of the stomach. Here's an example of uveitis. That's an inflammation of the vascular tunic of the eye, which is all of the iris, the ciliary body, and the choroid. And you can see all the inflammatory blood vessels here on the eye, and you can also see some misshaping in the iris here that's part of that ciliary body. I just wanted to remind you that inflammation is not the same thing as infection. Though pathogens can certainly cause inflammation, the inflammation response is much broader than that. Please also remember that the inflammatory response is stereotypical. By that we mean same events happen every time you have inflammation, regardless of the cause, and you never get better at it. That's one of the hallmarks of your pathogen defense that's nonspecific. Every time you do that defense, it happens the same way. Unlike in fighting a virus where you get better when you start to build immunity. So just want to take a second and remind yourself what the primary cause of inflammation is. Remember that it's tissue damage from any source, And that little mnemonic first tick can help you remember that. Often inflammation can be systemic. We'll focus on that in the next lecture. But in this case, that systemic inflammation gives us a test for chronic inflammation. So these are some signs and symptoms you would feel if you had a chronic inflammatory disorder. One of the tests we would use to confirm that is called an ESR, or erythrocyte, red blood cell, sedimentation rate. As we'll learn shortly, there are various proteins that are released during the acute phase, and we call those acute phase proteins. One of those proteins is fibrinogen. So if fibrinogen is being released because you're in the middle of an inflammatory response, your erythrocytes will clump, and they form a very specific type of a vertical clump called a rouleau. Those rouleaux are much more likely to sediment or precipitate out if you let blood stand for a little while. So if we look at this image on your right, there is a fixed amount of blood that has been sitting in the tube for a particular amount of time. On the left is a different sample from a different patient. And in the patient on the right, you can see that a lot of the erythrocytes have settled or sedimented down into the bottom of this tube. We would consider this to be a high ESR. The one on the left has a much lower ESR. So again, the diagnostic purpose of this is it's a cue that you have a chronic inflammatory disorder. So this is a diagrammatic version of different erythrocyte sedimentation rates, or SED rates. That's a shorthand for that. And notice the very top one that's associated with high sedimentation is chronic inflammation. Other aspects, infections, cancer, autoimmune disorders, can also lead to a high SED, and there are also certain indicators that would tell me I have a very low SED. The ones on the left we'll be talking about more when we hit our red blood cell disorder lecture. So this is a fabulous flowchart from Marieb that goes over both acute inflammation, primarily on the left side of this image. On the left is primarily acute and localized inflammation, and then the right side is more chronic. We'll focus more on the right side of this picture in the follow-up lectures, but in this lecture, we'll talk a lot about the left side. So notice down at the bottom, you see 4 of the 5 cardinal signs of inflammation: heat in the area, redness, both due to blood vessels dilating, and of course blood is warm, swelling that's tied to tissue leaking fluid, and we'll talk about that shortly, and pain that results for that. And remember, that can lead to possible lack of use. As we go through this, you should be able to come back and explain how each one of these symptoms is caused. As we go through this process, we're going to be thinking about many of the key players, the cells that are involved in creating an inflammatory response. We'll be talking about the endothelial cells. Those are the cells that line your blood vessels. They are secreting, they're active, they are not passive in this response. We'll talk about platelets, which you know are very important for clotting, various white blood cells, and then connective tissue cells out in the extracellular matrix outside the blood vessel. We'll focus a lot on mast cells. Remember, mast cells are similar to basophils. Basophils are in your blood, mast cells are in your tissue. In an acute or early onset of inflammation, we'll talk a lot about macrophages and neutrophils. If it's a chronic infection, then we'll be seeing the activity of lymphocytes much more. Fibroblasts will be very important in tissue repair. So all of these are players that we'll meet today as we walk through this inflammation process. This is a nice overview slide of some of the different phases and players in this. We start, of course, by inducing or causing inflammation, and remember that the starting cause is always tissue damage by any reason. Then we'll talk about some of our cells that are important in coordinating inflammation, the mast cells, which are going to be releasing mediators like histamine. We'll talk a lot about that shortly. Dendritic cells, which remember present antigen and recruit rest of the white blood cells. Macrophages and neutrophils. They will all be very important in getting the inflammatory process started. We'll also talk about lots of molecules that are mediators of inflammation. Those are released by these various cells and used to communicate. And then their target tissues. As we go through, we'll talk about all of these. This image is just to point out that once mast cells are activated and inflammation begins, there are lots and lots of chemical mediators that are released and act on different parts. Just wanted to draw your attention to some of that we'll talk a lot about today. Histamine, where you see in the red arrows, various interleukins underlined in blue, and TNF-alpha, tumor necrosis factor alpha, circled in blue. All of those are molecules we'll talk about today. This is a great overview of many of the mediators that we're going to meet as we go through the inflammatory process. Just wanted to draw your attention to many that are made by the liver. Among them, those acute phase proteins. I gave you an example earlier, fibrinogen, which is part of this. Remember that it causes that sedimentation of erythrocytes. That's an example of an acute phase protein. We'll meet a bunch of others as we go along. Also, complement proteins that we talked about in our pathogen defense. From cells, we have a variety of other chemical mediators. As we just discussed, mast cells release a ton of different mediators. We're going to focus on histamine. Platelets, you should have learned in 202, release serotonin. That's an important mediator. You know that neutrophils and macrophages are full of lysozymes, and they can also release reactive oxygen species. The macrophages and lymphocytes and endothelial cells that we're going to be talking about later today release a variety of different cytokines like interleukins. So the ones we are going to focus on, we will highlight. They'll be in bold to help you remember. Those are important mediators, but there are many, many, many mediators of acute inflammation. This is an example just to show you how quickly an inflammatory response can occur. In this particular case, this caterpillar fell out of a tree and landed on this woman's shoulder. And you can see that even within minutes, that's what marks it as acute. We see these pus fills or pruritic urticarial eruptions or hives forming all over her shoulder. Notice that this is very local, and again, notice since it happened within minutes, it's very fast. So that's an example of an acute inflammatory response. So we're focusing again on acute inflammation, as you just saw in the last slide. Remember that this is an immediate response. It happens within minutes, and it also usually resolves itself within, at most, a couple of days. If it continues past that, we would then call it a chronic inflammation. So this is the very first step in fighting pathogens. Any type of tissue damage leads to inflammation. Remember that it's non-specific, so it doesn't matter what the cause of the damage was. It's stereotypical, which means it happens the same way every time, but it can be more or less severe. So how severe it is depends on how bad the injury was. Also, other issues like temperature. You know, if you have an inflammatory response, one of the things that you can do to minimize it is use cold compresses. It also, of course, depends on your immune status. If you are deficient in some of these white blood cells, you're not going to be very effective at inflammation. And always keep in mind, inflammation is a helpful thing to help fight tissue damage. It is also the first step in wound repair, so you have to have the inflammatory response first, then you can fix the problem. And remember, this is the sort of goal of the 4 events in fighting tissue damage. So this slide reminds us of the major events in acute inflammation. The first event is a vascular stage. In this case, we will briefly vasoconstrict and then vasodilate, and that's going to bring more blood, and of course blood is red and warm, so that will account for the first 2 signs of inflammation. The next major event is the cellular phase. In this stage, the blood vessels become much more permeable, cells can leave, they will start interacting with other molecules, the white blood cells will migrate out to find pathogens if pathogens were involved. They will actually smell the pathogens, that's a process called chemotaxis, and move toward them. If there are neutrophils available, and this is a bacterial infection, for example, phagocytosis will be involved in fighting the infection. And in the end, of course, we have to stop the inflammatory process or undergo resolution. So that's the big picture. So we'll begin with the vascular stage of inflammation. Remember that this happens very quickly. Initially, we undergo vasoconstriction. That is part of the response of the vessel to pain. That is part of the hemostasis or clotting activity that we'll focus on in a different lecture. But very quickly after that, the smooth muscle in the blood vessel wall is relaxed and the vessel will dilate. At that point, we will get much more blood flow, and it should occur to you, if there's more blood flow, think about the two cardinal signs that are tied to this vasodilation. Take a second and write them down. So those two signs you should have come up with are the redness of the tissue and the increasing temperature or warmth in the tissue. So how do we get that vasodilation to happen? There are many pro-inflammatory mediators that are vasodilators. The big ones that we want you to know are histamine, that comes from the mast cells if you're out in tissues, or basophils if you're in the vessel itself, and nitric oxide. Nitric oxide is released from a variety of cells, including the endothelial cells. Remember that the endothelial cells are the cells that line the blood vessel. There are lots of other vasodilators. We'll talk a little bit about platelet activating factor, obviously tied to platelet action, and prostaglandins. When you see PG in this lecture, that means we're talking about a prostaglandin. So let's talk about our first cells that are going to help actually fight pathogens if that's the cause of the injury. The first responders in an acute response are our neutrophils. At this point, you've already experienced the redness and heat from the vasodilation, and the exudate has started to release, and you'll be seeing edema. These neutrophils are arriving in those vasodilated vessels, and they arrive within about an hour, hour and a half. There are lots of different names for neutrophils. They can be called neutrophils, of course. They can also be called polymorphonucleocytes. Poly means many. Morpho shapes, nucleocytes. If you look at the structure of this neutrophil and pay attention to the nucleus, you'll see that all of the nuclei have lots of lobes, and no one neutrophil looks exactly like another. All of these mature neutrophils have multiple lobes in their nucleus. They develop that as they age. Immature neutrophils are called band cells, so you can actually tell the difference between whether this was a neutrophil made some time ago or a brand new neutrophil. So if you're busy fighting infection and the neutrophils are leaving your blood, you'll see a transient decrease early in the plasma because those neutrophils are out in the tissue. But then as we start to release colony stimulating factors, leukopoiesis will occur, and then we will see an increase after that. But those cells that are increasing in the plasma while you're fighting an infection are newer cells, and they look different. They're called bands. And again, banded neutrophils just have many fewer lobes. Remember that neutrophils do a couple things. They are great phagocytes of bacteria, but they also release those reactive oxygen species like hydrogen peroxide and hypochlorite, which is the same molecule that's in bleach. So during their respiratory burst, they are killing lots and lots of pathogens. They also release more nitric oxide, and remember, nitric oxide is a vasodilator, so they are contributing to the continued inflammation. A given neutrophil will not last very long. It's so busy killing, it fills up with junk. It often dies itself in the middle of the respiratory burst. So a given neutrophil only has a short timeline, and as they die, they become a component of pus, along with all of the dead material that's being fought. The next cells to arrive are our monocytes or macrophages. Remember, monocytes, that's the term we use when we are in the bloodstream. Macrophage is the term you use in the tissues. These cells take longer to arrive. They usually arrive some hours later as opposed to about 90 minutes after the initial insult. That can be used to stage an injury. If, for example, you're doing an autopsy on someone who had a heart attack, depending on whether there are just neutrophils or macrophages in the tissue, will tell you how long ago the myocardial infarction occurred. So when monocytes exit the blood, they again change their name. They become tissue macrophages. There are also resident macrophages, but we're going to focus on ones that are leaving as part of inflammation. They do lots of things. Among them is phagocytosis. As we discussed, both neutrophils and macrophages are phagocytes. But remember, monocytes are also antigen-presenting cells. So they digest pathogen and present small amounts coupled to MHC2, which help alert T helper cells and the specific immune response that can occur. They also produce lots of key molecules that we'll be talking about that are mediators. They produce prostaglandins, leukotrienes. Those increase inflammation, so these are pro-inflammatory cells. They also produce platelet activating factor, which helps us coagulate the blood, growth factors that are very important for repair, and other cytokines that we use to communicate with other immune cells. That's part of this MHC presentation part. Because they secrete growth factors, they're very, very important in the resolution phase when we're cleaning up the mess. These are key players also in chronic inflammation. As we'll see in the next lecture, macrophages and also lymphocytes are major cues that you have a chronic inflammatory status. Eosinophils are another cell that we will see increased in certain types of hypersensitivity reactions. We will talk about those more in a later lecture on immune system disorders. They are also very good at fighting parasites, so if you have a parasitic infection that's the source of the tissue injury, then we will have eosinophils increasing in the area near the problem. So these cells are named eosinophils because they happen to have these red granules that stain with the stain called eosin, and you see an orangey pink depending on the particular stain. So these are very helpful again at dealing with parasitic worms. They're also very active in certain hypersensitivity reactions. They also will affect the amount of histamine in allergic responses, and we'll talk about that again in our hypersensitivity lecture. Basophils, remember, are blood cells. They're very similar to mast cells in the tissue, but basophils stay in the blood. They do not migrate into the interstitial fluid. They stay in the blood. They have dark blue granules in a basic stain. Those contain heparin, which is an anticoagulant, and histamine, which enhances inflammation. So when histamine binds to histamine receptors on the endothelial cells, that also increases the permeability. So they have a prime role in inflammatory responses. They also can bind IgE, and therefore they're very important in allergic reactions, which are type 1 hypersensitivity reactions. So basophils are very, very important in this process as well. Mast cells are very similar to basophils, but they are out in the connective tissue. They are connective tissue cells. So these are not basophils that have migrated, but they're very similar in their properties. So they are found in almost all connective tissues, but we have lots of them where we are most vulnerable to tissue damage. So we have many in the dermis of our skin, and the mucosa of your respiratory tract, and also in the mucosa of your GI tract. Those dark blue granules that you see where the arrows are pointing to those basophils, they contain lots of histamine. We've now talked a lot about its role, and heparin, which remember is an anticoagulant. They also contain TNF-alpha, interleukin-16, and several proteases. They're very important for turning on complement. Remember, complement is another non-specific defense that helps us fight pathogen, to stimulate coagulation later, and the kinin systems that we'll talk about. They produce many prostaglandins and leukotrienes, as well as platelet activating factor, and stimulate other white blood cells. Again, these guys also bind IgE, and so they're very active in allergic responses, which is just inflammation when perhaps you didn't actually want it to happen. So let's return to that wonderful overview flowchart that we looked at earlier. Remember, the process begins with some sort of tissue injury. That causes the release of a variety of chemicals. A notable one here we've talked about a lot so far is histamine. Histamine makes my arterioles, primarily capillaries and venules, dilate. That gives me more local hyperemia, which gives me the red color that we see in the site of injury. Because blood is warm, that site of injury also is much warmer. So that takes care of the redness and the warmth of those two cardinal signs. We also get capillaries becoming much more permeable. Again, particularly the permeable capillaries the permeable vessels are the capillaries and venules. They leak this exudate. Remember, that's water plus protein. All of that protein-rich fluid contributes to edema or swelling, which in turn causes pain and typically limits the action or use of that area. Those other inflammatory chemicals are also attracting those white blood cells to the area, and they are going to start to migrate in and start to act on the tissue area. So remember, as they come in, they marginate, which basically means they stick to the capillary walls. They crawl out of the walls, which can be called diapedesis, and then they start to destroy pathogen and eventually clean up the mess. So keep coming back to this picture. It reminds you of all of the major events in inflammation. Take a second and try to answer these two questions. Which cells are key in initiating acute inflammation? Focus on the initiation word and the fact that it's acute. And then think about which one of these is more likely to be elevated in the plasma in early inflammation. When you're ready, move on to the next slide. So just a quick reminder that the key cells that are starting the inflammatory process, getting that vascular phase to occur, vasodilation, are the mast cells. And remember, they're releasing histamine, which is a great vasodilator, and heparin, which is a great anti-clotter. Lots of these other cells will be used lymphocytes, particularly in chronic inflammation, fibroblasts when we're ready to heal, and macrophages will come on the scene, but it takes a while. If they're resident macrophages, that's a different story. They may be there already. You may remember that lung cells have, for example, dust cells that are living there all the time. The next question, which one is more likely to be elevated in the plasma early? Which cells are we recruiting first? Remember that neutrophils get recruited first, so they are going to come to the scene. Their production rate will go up, and we will get them to the scene in minutes. Monocytes, which will become macrophages, take longer. And remember, as all of these white blood cells leave the vessel, temporarily, their numbers in the plasma will actually go down. So we're going to focus on the next slides on the cellular mediators of inflammation. Cellular mediators. So we've already talked a lot about histamine. Remember that these cells have preformed granules of histamine that are released, and that promotes vasodilation and increased capillary permeability, the vascular part of the response. Other cell-derived mediators that we'll be talking about are platelet activating factors. Obviously, these activate platelets. And that, in turn, activates neutrophils and attracts eosinophils. So we'll talk a lot about those when we talk about hemostasis. The next set is a new set of molecules that are all derived from a molecule called arachidonic acid. Arachidonic acid is in turn derived from a phospholipid molecule that's in your plasma membranes. Arachidonic acid will get converted into prostaglandins. The prostaglandins will augment the histamine effects and work on vasodilation. As you'll see soon, we also convert to thromboxane A2, which is a primary molecule that causes constriction and platelet aggregation. Both of those are very important in the hemostasis or clotting activity. So arachidonic acid can get converted into prostaglandins, thromboxane A2, and also molecules called leukotrienes. Leukotrienes are the molecules that cause bronchoconstriction. So if you're having an inflammatory response such as asthma and your bronchi close up, that's from the leukotrienes. They also increase capillary permeability, but one of the reasons that we're most attentive to them is their response in bronchoconstriction. Both these prostaglandins and the leukotrienes are eicosanoid molecules. So that's a type of inflammatory mediator, all derived from arachidonic acid. So this is a very important image on the right. This shows you how arachidonic acid is itself converted from phospholipids that are in your cell membranes. Corticosteroids, like cortisol, they block inflammation by blocking that conversion. So if you don't have arachidonic acid, you can't make anything that comes after that. So that's how corticosteroids work. We call those the SAIDs. SAID stands for steroidal anti-inflammatory drug, and they work by stopping the production of arachidonic acid. Arachidonic acid is then converted using two different pathways, either into those leukotrienes that we mentioned a few minutes ago, or using the COX enzyme. COX is shorthand for cyclooxygenase, so it's an enzyme. COX will take that arachidonic acid and turn it into prostaglandins and thromboxane A2. We'll talk a lot more about thromboxane when we talk about hemostasis and coagulation. It is a prime initiator of vasoconstriction and the coagulation events that happen when we clot. Prostaglandins do all kinds of things. They enhance some of the activities. They induce vasodilation like histamine did. And they also induce that bronchoconstriction we talked about in asthma that's so problematic. We can decrease the production of prostaglandins and thromboxane with drugs that are called NSAIDs. The N stands for non-steroidal anti-inflammatory. So notice that that just acts on the right side of that breakdown. The leukotrienes are still released. So classic example of a COX inhibitor, an NSAID, is aspirin, ibuprofen as well. Tylenol is not an NSAID. It does not act on this activity. So you need to know that corticosteroids stop the production of all of these molecules. Aspirin and other NSAIDs inhibit just the production of the prostaglandins and thromboxane. So these guys are all molecules that help limit inflammation. If we are taking either SAIDs or NSAIDs, we're trying to stop this process and decrease inflammation. And that works very well. All of those molecules do that very effectively. This slide has more detail than you need to recall for the exam. It just shows you the two major pathways in some of the players. So again, steroids inhibit the production of arachidonic acid, and we see COX-1 and COX-2 inhibitors, like aspirin, decreasing prostaglandins and thromboxane. Just wanted to make a note on the right side of this picture. Leukotriene inhibitors specifically help asthma because they help with that vasoconstriction, but they leave the COX side of the process still occurring. So let's stop and think about this a bit. Here is an image showing you what arachidonic acid looks like and reminding you that we make leukotrienes from that. We make prostacyclin, which remember was that sort of shiny Teflon-like material that lines healthy vessels, thromboxanes, which get us clotting, and prostaglandins. A couple other points I wanted to remind you. Some of those prostaglandins cause fever. In other words, they're pyretics. So if all of this process is happening normally, you'll get clotting, inflammation, and fever. So think about why we prescribe aspirin to patients who have had a heart attack or stroke. Think for a second about that. Also think about why it's very prophylactic. It helps prevent future problems. So realize that if we've had a heart attack or a stroke, that means that a clot has inappropriately formed and blocked a key vessel. So if we want to decrease clotting, we can have you on prophylactic NSAIDs, taking a small amount of aspirin every day, for example, and you will make less of that thromboxane and less likely to clot. So that can be very helpful. Also is used as an antipyretic drug because, as we just discussed, some of these prostaglandins are pyretics, so if you want to have less fever, aspirin helps with that. What aspirin is absolutely not is a blood thinner. You hear that term all the time, but your blood is not getting thinned at all by aspirin. It's simply not clotting. So if you want to call it something, call it an anti-clotter or anticoagulant or antipyretic, but please never say it's a blood thinner because your blood is not getting watery and thin. That would suggest you're overwatering it, overhydrating it, and that's not what aspirin does at all. So let's turn our attention now to some of the other chemical mediators on the right side of this image. A key cytokine that is released by macrophages and lymphocytes and endothelial cells, remember these are cells that are all coming later in the process, is called tumor necrosis factor alpha, or TNF-alpha. It's named just based on where we first found it, but it's a very important inflammatory mediator. Also, a variety of interleukins are released by these cells. Remember that interleukin means literally between the whites. So these are molecules used by white cells to communicate with white cells. So these types of mediators are produced by activated macrophages. Remember, they take hours to arrive. Lymphocytes, which are particularly important in chronic inflammation, and endothelial cells themselves. Some of the functions of these molecules, they promote chemotaxis, so those white blood cells that are leaving the vessel can better find the area of damage and the pathogens if there are. They activate neutrophils that are already on the scene, and they activate endothelial cells. So there's some positive feedback and crosstalk here. These are also molecules that can have some of the systemic effects of a more chronic inflammation or the feelings that we have when we've had a pretty significant acute inflammation response, where you can see fever and anorexia, lack of appetite, malaise, just generally feeling crappy. So we'll talk more about some of those effects shortly. This is a really nice image showing you the production of TNF-alpha and the stimuli that make that happen. So over on the right, you see your T cells. T cells release interferon. Interferon turns on macrophages, which then release TNF-alpha and interleukin-1. Another stimulus of the macrophage is the presence of gram-negative bacteria. They, remember, have lipopolysaccharides on their surface, and that gets the macrophages going also. So the take-home message here is that macrophages are releasing TNF-alpha. That TNF-alpha talks to endothelial cells, causes them to change their behavior, talks to neutrophils, gets them to aggregate and start to work, and causes that acute phase response that we talked about it briefly on the last slide, where we have various proteins that cause fever and anorexia, etc. Now let's turn our attention to the left slide of that image. And instead of thinking about mediators that were made by the cells in the area, let's think about some of the mediators that are made by the liver. These are all proteins. They were made first in the liver, and they have to travel to the injury site. Because they are being dumped into the blood, they can have systemic effects. Complement is a good example of a plasma-derived mediator made by the liver. We talk about complement when we remind ourselves about phagocytosis. Remember that complement proteins can latch onto antibodies or pathogens and opsonize them, making it easier for phagocytosis to occur. They also enhance the inflammatory response. So the presence of complement gets me more inflammation. This is another non-specific response. Another molecule that's made by the liver, or group of molecules, fall into a family called the kinins. One that you should know by name is bradykinin. Bradykinin is increasing that vascular permeability and giving me more edema. It also causes smooth muscle contraction and pain. So the kinins are particularly responsible for pain. There are also all of the clotting and fibrinolytic proteins that we see when we talk about hemostasis. So think about molecules like fibrinogen. We talked about fibrinogen in the beginning of this lecture as an acute phase protein. Those acute phase proteins, remember, you can measure if you're trying to find out whether there's systemic inflammation by looking at that erythrocyte sedimentation rate. The more of those acute phase proteins, specifically the clotting proteins, the quicker that those erythrocytes stack and sediment. So we're going to be focusing a lot on acute phase proteins here. So these acute phase proteins are one of the types of proteins that are giving you those feelings of fever and malaise. That basically why I feel so crappy if I've got a chronic or systemic inflammatory response. So we've already discussed, and I just reminded you, that fibrinogen is an early response, a protein released in the acute phase that contributes to a high erythrocyte sedimentation rate that can be used to diagnose inflammation. So again, if you have a high ESR, that's a cue that you have systemic inflammation. Another one that's very important and used a lot to help diagnose inflammation of your vessels and atherosclerosis is C-reactive protein or C-reactive peptide, CRP. Please make sure you know the word CRP. An elevated CRP is a sign that you have chronic inflammation or systemic inflammation. Serum amyloid A is another acute phase protein. Remember that serum is your blood plasma minus the clotting proteins. Hepcidin we won't talk very much about. Hepcidin is one that has to do with iron, and it keeps the iron regulated. It's a key regulator of the entry of iron into circulation in mammals. If hepcidin level is abnormally high, which it is in inflammation, serum iron falls as iron is trapped within macrophages and liver cells. So the amount of iron we have is tied to hepcidin, and that, of course, is tied to how we're able to make hemoglobin and anemia. So we'll talk more about iron and hemoglobin and anemia in our red blood cell lectures. So I want to remind you again that these are proteins made by the liver. The liver will increase production of these proteins because of the cytokines that it's seeing. So that TNF-alpha and the two interleukins, 1 and 6, that we just saw a few moments ago, they will stimulate the liver to release these proteins. These are all made by the liver, and those proteins will then have their systemic effects. So remember that these acute phase proteins are going to be systemic system-wide. Again, they cause all of those things that make you feel crappy when you're fighting a systemic infection. They also stimulate leukocytosis. And remember, initially there's leukopenia. Penia means less as the white cells are leaving the vessels, but then we turn on leukocytosis and we increase leukopoiesis and get more and more cells. As fluid is leaving your vessels in inflammation, if there's less fluid, that means you will also have hypotension or low blood pressure. And remember, that in turn causes tachycardia. So remember this concept: cardiac output is equal to your stroke volume times your heart rate. If you have less blood pressure, less venous return, less blood coming into your heart, then your stroke volume will drop. The only thing your heart can do about that to keep the output the same is to increase the heart rate. So the goal is to keep cardiac output relatively constant, and the trick is tachycardia, or increased heart rate. So we'll talk more about those. If this is chronic inflammation, then we're likely to see anemia. That ties back to that hepcidin molecule that we talked about a few minutes ago. Hepcidin is binding up the iron, making it unavailable for making hemoglobin, and that results in anemia. So these next two cells you can work through at your leisure. This is a wonderful summary of all of these chemical mediators and who produces them and what those chemical mediators do. So take your time on these, use your pause button to work through and remind yourself of some of these molecules we've been talking about so far. The next slide has another set of these molecules. This slide is just a reminder that you don't want to let inflammation continue out of control. You need to be able to turn it off as well. So there are various stop signals, anti-inflammatory natural molecules that we make that we know will shut this process down. We understand a lot less about how we turn inflammation off than we do about how we turn it on. So you're not responsible for any of the details of these, but it gives just a reminder that we do need to, in fact, turn inflammation off when we're done. In the next lecture, we'll talk about what can happen after you've had an acute inflammatory response. One option, and this is what you hope for, is that you simply resolve the issue. The tissue is damaged very little, and you can regenerate it very nicely without scarring. That would be ideal. That's your plan A. As you know, though, if the damage is significant enough, you may see scarring as part of the healing process. In scarring, instead of replacing tissue with native tissue, you replace it with collagen and fiber. So that would occur whenever the damage is significant enough that the tissue cannot regenerate. It also occurs in tissue that doesn't regenerate at all, such as neurons and heart cells. If you have injury to those kinds of tissues, the outcome is always going to be scarring because we don't get good regeneration in those tissues ever. We sometimes will see the formation of an abscess, which is basically walling off the pathogen if we're not able to actually kill it. We'll talk more about that in the next lecture. And again, this can progress into chronic inflammation. Chronic inflammatory diseases have been linked to all kinds of systemic problems, such as atherosclerosis. So we'll be talking about chronic inflammatory disorders all the way through the rest of this course.